Our mission at the National Center for Wellness and Recovery is to inspire hope and develop innovative evidence-based interventions to improve the lives of those living with pain and substance use disorders. We do this by investing in treatment, training, programs, and research for every stage of life. Dr. Furr-Holden is Associate Dean for Public Health Integration, C.S. Mott Endowed Professor of Public Health, and Director of the Division of Public Health at Michigan State University. She's also the director of the Flint Center for Health Equity Solutions, funded by the National Institute on Minority Health and Health Disparities. She's an epidemiologist and classically trained public health professional with expertise in behavioral health, equity, and health disparities research. Dr. Furr-Holden has worked extensively with a wide range of partners, including community-based organizations, local municipal officials, and national policymakers and leaders on the community-driven structural interventions to prevent and reduce substance use and related harms. Her research has supported legislative efforts to impact state and national level legislation to promote health equity, including community availability of medication-assisted substance use treatment. Among her many awards, she was a recipient of the 2006 Presidential Early Career Award for Scientists and Engineers from the Office of the White House. Dr. Sadler is an assistant professor in the Division of Public Health at Michigan State University and the director of the methodology core of the Flint Center for Health Equity Solutions. He is a geographer by training with expertise in geographic information science and land use issues in Rust Belt cities, particularly around the landscapes created by racially motivated disinvestment and economic decline. His work integrates principles of community-based public health research, including public participatory mapping, with the goal of giving voice to and building capacity among the populations he works with. His more recent work in the legacy effects of discriminatory housing practices has led him to serving as PI of an NIAAA R21 to examine the impact of redlining and blockbusting on contemporary food and alcohol landscapes. With that, Drs. Furr-Holden and Sadler, I'll hand over hosting to you to share with us about the upstream determinants of opioid disparities and why equity matters. So wonderful to have you with us here today.
Okay, great. So I'm going to just give some foundational stuff. We throw terms around a lot. We talk about disparities and equities. Let me tell you what we mean when we say that. A synonym for disparities are differences, right? So we're talking about differences. Mostly when we talk about disparities, it tends to be person-centered or maybe even group-centered. This group has more than that group. African Americans have a greater risk for that, or people with disabilities have a greater risk for that. We're talking about and basically describing individual or subpopulation level differences. Mostly disparities are the things that we see downstream, and I'll say what I mean in a little bit about that. And as we think about in this season, we talk a lot about race and racism, and I've heard somebody say more than one occasion that race is a social determinant of health. Race is not a social determinant of health. Race might be an individual determinant of health, but what race does is give way to this thing called racism. That is the social determinant of health. And I'll touch on that on the next slide. Inequities, synonym for equity is fairness. So when we talk about inequities, we're talking about unfairness. That deals more with systems and structures than it does as much with people or groups of people, right? We don't like the victim blaming, but we do it all the time. So inequities are dealing with the systems and structures. Typically, inequity happens upstream, and they say the stuff rolls downhill. So inequities tend to occur way further upstream, and that's where this thing called racism would reside. It's in the world of systems and structures and inequity. I always try to give a little bit of foundational, make sure we're all in the same conversation. And I just want to preface this with, I place no value judgment on any of these, but it's important ways for me to encourage others to think about how we solve problems. So imagine you're at the baseball game and you've got the profound privilege of getting a standing spot on the sideline, literally the best view of the game. Well, clearly you don't want the balls rolling over and things like that. So here we have this fence. And in an equality model, you have some problems. You can see those two guys can't see over the fence. So we've got whatever resources we've got. There's 3 boxes on the side. In an equality model, and I'm telling you, we used to do this. We take whatever the pie was and we divvy it up into equal pieces, and everybody got their piece of the pie. But you can see for the tall guy, he didn't need the box. He could already see over the fence. And for the smaller guy, even with the box, he still can't see over the fence. Equity.
That would be Debra at a baseball game. I would be this tall guy here.
Yeah, I'd just stand on Rick's shoulders or say, hoist me up. So what's out on the field? Let's pretend that's everything one would need for optimal health. And let's pretend that the boxes are the resources that we have, federal dollars, programs, clinic hours, all that. In an equity model, what we do is we redistribute those resources in a way that seems more fair, where people get what they need to have access to the game. In this, sort of stretch of an example, optimal health. It's really funny. The first time I presented this in Flint, somebody said, yeah, doc, we got it, but how'd that little guy get up there? Did the tall guy have to hoist him up? People should be able to maintain their dignity at the game or maintain their dignity getting health. And why do we need all of these resources? Why don't you just get rid of the fence? And so another way to think about it is social and what Daniel Dawes calls political determinants of health. And that's really about dealing with the context, systems, and structures and barriers that people face in experiencing everything that they would need for optimal health. And largely defined social determinants of health are the environments and the context in which people live and work and play and age and worship that impacts not just their health, but their health behaviors and their opportunities for health. So that's just sort of a little bit of a foundation. I'm going to hand it back over to Rick now, and then we'll do upstream, downstream later.
Yeah. So within that framing, one of those social determinants of health in particular that I think about is the built environment. And that was a point that connected mine and Debra's work early on when we became colleagues about 5-6 years ago. And so the way geographers think is that the environment influences health behavior in very specific and in very different ways. And so, so imagine you live in one of these cities. The physical form of the city, first of all, will influence what you do and how you move around and what method of transportation you use to get around. But it will also influence the types of exposures that you encounter throughout the normal course of a day. And so some of the work that we've done collectively that we won't talk about so much today has kind of tried to look at an aggregate perspective on what about all the good and bad things in the built environment? How might those things moderate the influence of, say, interventions on the influence of these interventions on the health behaviors that they target? So if you have two identical people, but one lives in Mississauga and one lives in London, and you give them the same type of intervention, how does where they live impact how they can adapt to that intervention? And so I talk about the structural determinants that are kind of interest to geographers, urban health geographers like me, are these. I mean, obviously there's many more, but some of the ways that we think about these include, for example, housing. So the ways that people were excluded from certain neighborhoods by redlining, the ways neighborhoods were emptied out by blockbusting and white flight in the 70s and 80s, and the legacies that those have today. So does living in a redline neighborhood impact your opportunities today more so than your socioeconomic status? And then thinking about urban form, like, again, kind of like the slide I mentioned, where the city has physically changed shape. And in Flint, that's a particular concern because our urban core is very heavily disinvested. There's a lot of neighborhoods with vacancy rates above 50%. And so a lot of businesses and schools and churches have closed, and there just isn't anything there to access anymore. And so access to goods and services and healthcare becomes a big challenge. But conversely, our suburbs are also very spread out, and you need a car to get anywhere in those places. So that kind of setting, even living in, say, Genesee County, Michigan, versus if you lived in Columbus, Ohio, or Jacksonville, Florida, or something, impacts your behaviors. And then we talk about economic change. That's all the stuff, particularly in Flint, around deindustrialization and urban renewal, and the way that we obliterated our cities to build arenas and stadiums and freeways, and the people who are most heavily impacted by that shift. And then the societal change kind of stuff is, things like the erosion of social cohesion in American society and the war on drugs and the whole neoliberal political atmosphere that we've lived in for the last 40 years, where we've scaled back the resources available to people. And so even when we're taking this lens toward social and political determinants, we have a smaller pie to divvy up equitably in the first place. And so looking at all those determinants, and this is, again, this is the perspective I take in all of my work, whether it's more economic development and urban planning focused, or whether it's more on the side of public health, is that the general idea is that American quality of life has declined in many ways. The places we live, the communities we inhabit, the opportunities we have, the compensation we receive in employment. And as the political system shifted toward big business, of course, you know, we know the ways that the opioid crisis has been kind of pushed along by that emphasis on, yeah, no, like big business will just take care of us and everything will trickle down and we'll be good, right? And so it's in that context that we see these increases in mental health issues and chronic disease. And again, for me, it's important to think about how the built environment has become increasingly segregated sociospatially. So not just racially, not just socioeconomically, but the physical distance between different groups of people has increased as we've spread out into the countryside. And it's just a little slow here. There we go. Okay. So back to Deborah. Oh, you're still
being great on mute, we're gonna sort of move toward now, what does this mean for, you know, inequity more broadly, and the work that we've been doing around opioids. And so you hear this distinction between upstream and downstream often, and it's really cool, right? It comes out of the geology literature. And upstream is the source of the river, right? And again, I say this sort of stuff flows downstream. So you got to think, the question is, what are the things upstream? That's mostly laws, it's policies, it's resource allocation. It's the things that are already fixed and flat and sort of baked in, if you will. And those things flow downstream and they impact what we see in the landscape by way of the thing that we call disparities. Typically, what I always remind people of also is what's downstream typically costs a lot more money than the things upstream. It's not free to change policy, but we do have elected officials whose job it is to legislate and create policy that creates fairness and opportunities for optimal health for everybody fairly and equitably. When you get downstreams, we're talking about programs and treatment and care, and those things tend to be really expensive. So we are in the push to mandate equity. And what does that mean? Well, I fundamentally believe that our natural drift is to inequity. If we do nothing, something that's well-intentioned will naturally drift to inequity. We saw that with the COVID vaccine and the initial rollout. It was supposed to be available to everybody, but we had massive barriers for people of color, for people in rural communities, for people without transportation, you know, just all of the things about what's sort of baked into our society already just play themselves out. And so the thinking is that mandates or legislation for equity would actually inspire communities of practice, because there are some places who just do a much better job of it. And I sort of forgivingly acknowledge that equity is just a weak muscle for us as a nation. It wasn't how we were set up. You know, women were by design when the country was founded, meant to be in a particular, you know, position in our society, as were people of color, you know, as were people with disabilities. And so for the places that are doing better, whether they be cities or counties or states, if we had mandates for equity, if, for example, with the COVID vaccine, we said, you have to demonstrate that you can and you are getting the shots in the arms of people fairly and equitably, it would have encouraged states and counties that were struggling to reach out and be practice informed and evidence informed by places that were doing it better. This has major implications, and we'll talk about that later, in the world of addiction. And we know this. Legislators write laws. I think we learned this in the Schoolhouse Rock video, how a law becomes a bill, and then maybe again in 9th grade civics or something. Legislators write the laws, and then we need executives to enforce those laws. And it's critical. People need skin in the game. Those laws have to be written, they have to be enforced and enforceable, and they have to be attached to resources. If there's no penalty for breaking curfew, we would never honor curfew. If we need incentive, the point is for equity and disincentive for inequity. What does that look like? I love the case of Flint. So if you look at our study in context, Flint, Michigan, we're more than the water crisis, but we'll talk about that for a quick second. Flint is the birthplace of General Motors and organized labor. Many Americans don't realize it is also the birthplace of the American dream. That's what we say, because Flint was a place where you could graduate from high school, go get a job in the plant, buy a house, get you a brand new car right off the line, send your kids to college. I mean, that's like sort of the basic version of the American dream. We are also the poster child for deindustrialization and the radical effects that deindustrialization and divestment can have on a community. The Flint water crisis is a shining example of that. So what inequity looks like, and just to put it in context, and I always say there's a business case to be made for equity. The Flint water crisis has cost more than $1 billion of taxpayer money, and it's going to now cost an additional $1 billion to rebuild our water infrastructure. What was the cost to upgrade our water treatment system pre-water crisis that could have avoided this? It was less than $1 million. And what was the complaint? We don't have the money. So we didn't come up with $1 million. And now we're going to be about $2 billion in. What was the cost of an anti-corrosive that could have largely prevented the corrosion of pipes and leaching of lead? And there were many, many more things wrong with Flint water in that crisis. But if I just pick on that one thing, the fact that we now had a lead contaminated, water distribution system, and what was coming out of people's taps really was not potable. Depending on who you ask, it was somewhere between $81 and $150 a day. What's the cost of human capital and human potential? We don't know. That is still to be determined. Thank God for public health and evidence-based interventions to try to undo some of those effects and the damage that was done. But we won't know. It's going to be the nasty gift that keeps on giving. So now the next question, and to put it in context for this work around addiction, is what is the cost of inequity in substance abuse and addiction? And we'll talk about that, but I do think that's something that NIDA also is getting increasingly interested in.
Mm-hmm. Yeah, and to that, I can add both Deborah and I spent all our parts of our childhood in Flint, in and around Flint. And so for both of us, it's personal. We've seen this across generations with parents and aunts and uncles and with our individual experiences living in this community. So that's something that drives our work here, as well as the work that we do in Baltimore, Baltimore being one of Deborah's other home cities over the years.
Yeah.
And so, yeah, so with all that framing, the next piece of what we're going to do is share the results of some of our research. And we've kind of threaded together maybe 3 or 4 of the papers that we've done collectively, starting with a paper on clustering of opioid overdose deaths in Flint, Michigan. And then we'll kind of segue from that, thinking about the equity implications given the data available that we used in that paper in the context of this other paper on uncovering emerging disparities in opioid overdose deaths nationally. We'll briefly mention the Strengthening Flint Families program, which is one of the interventions of the Flint Center for Health Equity Solutions that Deborah is the PI on, and I'm the methodology core director for. And then we'll talk about implications for prevention and treatment services. And then we want to make one kind of asterisk to make a point about how we used the same kind of infrastructure to respond to the COVID pandemic with an equity lens here in Flint. And so I'm new to drugs and alcohol. Deborah likes to joke that she got me into drugs and alcohol. And this happened in the last couple of years. So I'm edgier than I used to be, I guess. But for me, it's the same basic principle, whether I'm studying food access or access to healthcare services or exposure to lead in water lines. The idea is to put them on a map, look for clusters, like use the analyses I have to see if there is some kind of spatial cluster, and then ask what other things are coincident in that space and how can we use that to target intervention. And so with respect to heroin and opioid use, we know that it's generally been more common in low income and Rust Belt communities, and up until a few years ago, also more common in the white community. But another thing that a lot of these communities have in common from Appalachia into the Rust Belt is that they've experienced disinvestment. So there's higher unemployment rates, there's concentrated poverty, there's often that sociospatial segregation that I mentioned. And then sprawl is kind of this additional aspect to it, because part of the function of sprawl in declining communities is that it's not the same as, say, a sprawl on the East Coast or in California or Texas, where you've got occupied strip malls everywhere. In Flint, the sprawl is vacant strip malls everywhere, and the city has vacant storefronts everywhere. And so the way people encounter and interact with those communities is very different. And so with respect to the first project, we originally got some data from the 911 consortium through a community partner. And this kind of happened alongside the very start of the Flint Center for Health Equity Solutions, but then wound up being really useful to our Strengthening Flint Families program. So we got the location of every overdose death over the course of 3 years of data, as well as the date and time. It was the location of the death, not the location of the home of the decedent. But one kind of side point I can make, and this has to do with our desire to stay focused on equity, is that it took us 5 years to get newer data. So we had this 2013 to 2015 data, and it wasn't until last year that we even had like a really good pulse on another data set of really localized data. It was usually at the zip code or the county or some really big level. And for a geographer, it's all about granularity of data. You want the address of where something happened or is. And so we used a couple of GIS techniques called kernel density analysis and spatial joins. And honestly, as a GIS person, a spatial join is one of the easiest things you can do. It's literally just, you've got a layer and you've got a point, and you just stick the layer on the point, and then you extract out the value from the layer onto that point. And you do that for hundreds or thousands of points, and then boom, you've got new columns in your data set that you can use as variables. And so this is what the landscape of heroin and opioid overdose deaths looked like in Flint. And you notice it's very clustered in 3 specific neighborhoods. The Lincoln Park neighborhood is where I grew up going to church, Corona Road corridor, and then the east side. Something about these neighborhoods is that they're all poor white neighborhoods. And so if you look at the time frame, you can kind of get in mind, right, like the opioid epidemic was, it was ballooning among the white population at that time. And so initially we did use this for some of our response for targeting those locations. Oh, right. So so this slide has a lot going on. The little dots are population by race. The bigger dots, the purples and reds, are different types of facilities that might offer substance use disorder programs or single room occupancy residences like motels and shelters.
Presenting.
And so, oh, sorry, did you need some, Deborah? Okay. Yeah, so like I mentioned, they're in poorer, whiter neighborhoods, also neighborhoods that tended to have higher vacancy rates and other kind of built environmental risk factors. One thing we noticed is that there was a lack of overlap, first of all, with the single room occupancy sites, but also with the existing service sites, places where people could go either to get treatment or to get connected to treatment. And so this was kind of, again, it's useful because if this data is up to date, when the data is up to date, we can use that as a reference point. But the thing is, the data availability lag is that we know trends have shifted, right? And the thing about Flint, and so I'm going to highlight these blue and green dots now. The blue dots are the white population of Flint. The green dots are the Black population of Flint, which is predominantly historically in the northwest side of town, and then kind of in this segment here in the east side of town, but not so much in the northeast, which was actually very virulently racist through the 60s, 70s, and 80s. So they're really, like, the Black population didn't break through into the east side because it just wasn't tenable. But then also the historically white south side. And again, these patterns are changing a bit as our distance from that era of blockbusting and white flight gets farther along. But what we were seeing here is like, okay, it's the poor white neighborhoods, right? But if we were to look at the data today, it would probably tell a very different story.
Yeah, and so this is something else that we took on because we're looking at the sort of most extreme outcomes from opioid involvement. And I do underscore the point that Rick made. It took 5 years to get new data. I remember saying, Rick, just get the new data. Like we have to understand this over time. And we'll talk a little bit about that when we get towards solutions. But we know fundamentally that opioid overdose death is preventable and that opioid addiction is treatable. We also know that the social and political determinants are key drivers of opioid overdose death and the disparities that we see both in rates of addiction, recovery, and in opioid overdose death itself. And too often the solutions that we implement or the interventions really don't match the level of the problem. And I'll talk a little bit about that after I tell you what we uncovered. So we found foundationally, historically, opioid overdose death has been much higher among whites. I'm basing this on a 20-year analysis of trends in the National Vital Statistics System, which is probably our best system for classifying opioid and other drug-involved death. We had HHS that declared a national opioid epidemic in 2017 and rolled out massive amounts of resources to combat the problem. And people were kind of up in arms, right? I was in Baltimore. Rick said that. Baltimore's got a little piece of my heart still. And my soon-to-be granddaughter is in my daughter's belly. Yes, I will be a grandma. And but people in Baltimore said things like, we've been dealing with the heroin problem for decades. It's a port city. There was a point in time when 1 of 8 Baltimore residents was an active heroin injector. I mean, it's just been a major problem. And then opioids and illegally manufactured fentanyl and other seminal trends pushed the opioid problem. We've all heard about the opioid settlement. This group is in on that, but it pushed it into the white middle class population, and it raised the alarm. And I thought, as somebody who's devoted their life to combating addiction and drug dependence, I thought, I don't care how we got here. The fact that HHS is now using evidence-informed strategies, the fact that it's been declared a national epidemic, to me, that was great news. And what happens the year after this massive rollout, we see our first national decline following that HHS declaration. And then I said, let's get our hands on the data and look at it ourselves. So myself and Rick Sadler and 2 of our other colleagues got the data, and we looked, and all we did, it's a 101 in disparities research. You just disaggregate the data. And what did we find? In fact, that the decline was solely attributable to non-Hispanic whites. Not only was it solely attributable to non-Hispanic whites, there was a statistically significant increase in the rate of opioid overdose death during that same time period for African Americans, and a non-significant, but very close to it, for Hispanic and Latino populations, mostly because their numbers are small. We continue to do that work and look. So we say we've got a problem, and it's an emerging problem, because if you think about running a race, somebody might start the race off far ahead of you, but if you're running faster than them, you will catch them. So African Americans and Hispanics are now far outpacing whites in rates of opioid overdose death. And don't get me wrong, what our goal would be to flatten the curve for everybody. But if you look, you had this seminal trend. That bottom line represents opioid overdose death in African Americans, and then introduce illegal fentanyl. And then the following year, between 2012 and 2013, you get this rapid acceleration among African Americans, and the slope continues to increase. And then when you look at whites, they've been increasing steadily over time. They too got impacted by other opioid products hitting the market. They get this upward trend in 2013, and then they get another increase around 2016. But then we roll out the resources, and we start to see this downturn curve. I can tell you with one additional year, and this was data from 1999 to 2018, because that was what we had at the time. You can now look at, 1999 through 2018. When you look at 2019, these trends still hold up. It's a really unfortunate state of affairs. And the question that I asked to myself was why? Why did this happen? How is it that we got this declaration, a very thoughtful, to me, 5-point strategy, strongly evidence informed? And what we see when we unpack is that we racialize much of the opioid prevention and intervention efforts. Again, go back to my earlier statement, our natural drift is to inequity. We actually have to do something highly intentional and equity driven with equity at the forefront for it to be some other way. Couple of quick examples. One of the strategies was starting people on medication assisted treatment in the ED. I've looked at various data sets, and lo and behold, if you look here in Michigan, the strongest predictor of who gets started on medication assisted treatment in the ED is being white and having private insurance. That's who's the most likely to get started on medication assisted treatment in the ED. When you talk to providers, they'll tell you things like, well, this person was unstably housed, or they've had failed treatment attempts in the past, and things like that. But again, if you look at the sort of structural barriers that people face and these upstream factors, they're living in systems that are rigged against them. So one might have more disruptions in treatment if they have transportation problems, or if they don't have insurance, which is attached to employment, and they have lapses, if they have a brief period of incarceration and lose entitlement benefits and have to come back online. But I thought being able to explain the problem doesn't justify preferentially starting people on medication assisted treatment in the ED. We know there's no real wrong door. Once you get people into a system of care, the goal is to get them treated and get them started. And unfortunately, that is something that very much got racialized. And there is a collapse clearly between race and economics, because, you know, private insurance is also, one could argue, an experience of privilege, and consistently having private insurance. If we look at naloxone administration, and there's several published papers on this, if you're African American and you get an opioid prescription, you're much less likely to also get a concurrent naloxone prescription. We looked at some of the data that we had in Baltimore on widespread distribution of naloxone, and they just do a better job of getting it in communities that are slightly wealthier and slightly whiter. Things like recovery-oriented systems of care, right? We know that people can and they do recover, but a part of recovery, and a big thing that people who are, in that recovery process deal with, is housing. And we have major inequities in who's able to secure stable housing and who's able to access peer recovery and recovery oriented support services. And oftentimes, and we did a separate study in Baltimore, African Americans were less likely to be able to use housing vouchers and get into more stable neighborhoods. They were basically taking their housing vouchers back to very poor, highly distressed communities compared to their white counterparts. So if we can take things that we know work, but if we don't bring equity to that work and their application, and again, I go back to, it needs to be legislated. It has to be legislated, and then it has to be enforced. We saw similar breakdowns with the rollout of affirmative action. The groups that it was largely supposed to hit and impact, many of them simply just got left out of it. So I think that accounts for a lot of what we see in that big gap. So what does that look like as we think about our COVID disparities? And I'm sorry, I've skipped too far ahead, Rick, sorry. So solution, sorry, Rick did all the heavy lift for this, so.
I've got notes in front of me too, so it's easier.
Yeah, and I'm gonna stop ad-libbing too and move it along. So what are some of the solutions that we've put in? And this is, again, really cool work that we've done out of our Flint Center for Health Equity Solutions, which is fully community and academic partnership. So I have a strong partner, one of our leading treatment providers in the city of Flint. They actually have recovery communities and supportive communities all across the state, is the Flint Odyssey House. And what we did is we developed this multi-level intervention. And I said, let's take the things that we know work, and let's do the research on how to get them to take hold in the community. And the community partner was great, because she said, great, because we're tired of you guys and all your clinical trials and all your this. Like, that's what we want. We want to understand. And don't get me wrong, a lot of innovation has come out of clinical trials and controlled trials, and I'm not dogging them. But at some point, we have to start to shift that paradigm and say, if we know what works, the question is, how do we work it? And so what Strengthening Families is, it's a multi-level intervention program to make effective substance use disorder and prevention programs available widely in the community. And the real goal is to increase individual and family capacity to respond to crisis and to promote self-efficacy, people's ability to get their own needs met. And I'm really proud of one piece I'll just highlight here, which is peer recovery coaching. We started a peer recovery core. When I say we, I don't mean the Flint Center for Health Equity Solutions. I mean a network of partners, people in long-term recovery, people who were early in their recovery process, multiple treatment providers. We had to do some fighting with the state to make sure that they didn't put wonky guidelines and criteria in for who could be certified as peer recovery coaches. And I will tell you that happened. They tried to rule out anybody who had had a criminal conviction in the past 2 years. And my response was, well, stop locking up people with substance use disorders. If you would stop locking them up, then they wouldn't have criminal records. We did not know that COVID was coming and we would see the massive disruptions in behavioral health care. And I know, because they've said it, that peer recovery core has been a stake in the ground for people maintaining and supporting their recovery throughout the COVID crisis. So, you know, who knew nerdy researchers could partner with communities and actually do things that would be sustainable and have us be prepared in times of crisis?
Yeah. Well, and yeah, as a geographer who'd just gotten to MSU when we wrote this grant, as a person who didn't live in the world of clinical trials at all, the only way I felt I could be helpful and something that I'd started building my career on was community-based geographic type research. So participatory mapping, like participatory planning kind of stuff. So all of this just made perfect sense. And I think it's really prescient that this program started, well, that our connection to the existing program started as the gap, the racial gap narrowed and potentially inverted, because Flint is a community that's 60% African American. So in the context of the work that we've done and the Strengthening Flint Families program, we've made this mapping and like these analytical, kind of spatial analytical results available to them. And the idea is, particularly with updated data sets on locations of overdoses, we can use that mapping to get Narcan and naloxone into the right places, and then also potentially distribute these other kinds of support services to communities, whether it's churches or community centers, where there might be a big impact. I think this is maybe we have one. Yeah, we have one more, and then we'll talk about COVID. And so some of the kind of policy points from the, I guess from kind of all of this work overall is that, so we need to have our thumb on how do these racial disparities shift over time. In Flint, which is still very segregated, sociospatially segregated and racially, if we're looking at a data set from a few years ago that has a very strong connection to race, and then that influence changes over time, that whole pattern is going to change. We're also still working on building those partnerships that make that data available, because like Debra said, it was impossible for us to get that updated data for years. And then how we can use that data more effectively to rapidly increase our response. So we map it, we put it online, we share it with our partners, we ask them how they can use it. And then, so we've used the same infrastructure to address some COVID-related disparities.
Yeah, and this is also speaks to the power of community academic partnerships. And different people mean different things when they say community. I include in our work around strengthening families, we've got, local healthcare providers and substance abuse treatment providers and mental health providers. That also includes people in the recovery community. It also includes churches and grassroots community organizations. We, as a function of the Flint water crisis, really have a city of people who are highly mistrustful. And I say it's a well-earned mistrust, right? We can talk about things like divestment, and Rick sort of threw out some urban planning terms, blockbusting and redlining and white flight and some of those other things. But you got to imagine, for the people who've remained in this city for multiple generations, this has been their lived experience. And so our health department became a place that in an ideal world, the health department is where you go for local health information. But if you can imagine, it was our health department who the city, was looking at in large part failed them and didn't give them fair warning about the Flint water crisis. And in fact, gave recommendations that the water was safe to drink when we find out later that there was some evidence that it was not. And in fact, it was not safe to drink. So we've had a lot of changes that have happened in Flint. I've been back in Flint for 5 years. We are on our 3rd health officer for the city of Flint. And so this is a partnership that we're really proud of. And I could just say we partner with the health department, but that is not trivial. And the person who was our last health officer, who was a great guy, he'd been in Flint before, but was nearing retirement, sort of really worked closely with us, and as one of his last acts, made sure that we penned this agreement because they just simply didn't have the capacity to do this. So Rick and I had a conversation and said, look, are we up for this? By we, I mean Rick. But I always like the we, kind of the French way of saying, can I make some promises, Rick, and can you fulfill it? And he did. And he worked really closely with a struggling health department, with an outgoing health officer. It took 3-4 months to get a data user agreement in place. What we had before that for COVID was every week we would get updates on our webinar of total numbers of COVID cases, nothing disaggregated by race, nothing broken down really well in smaller geographic units. And Rick and his team stood up a interactive COVID data dashboard with an equity lens. You can look at geographic variants. You can look by race, by gender, by age. It's just nothing short of a miracle. So the short version is when we started, and I don't know if you saw, Michigan was one of the first few states to report transparently on our COVID disparities. In the state, African Americans were 14% of the population, 15%, and were 32% of cases and 41% of deaths. Flint looked very similar, right? We're a much more African American population, but we were 1.5 to 1.7 times overrepresented African Americans in COVID cases, and the numbers were even worse for COVID death. And so a lot of that was eliminated, and we did close that racial gap in COVID cases and deaths. Data was a big part of it for us because we also had to first have a real reckoning with the truth of where we were and what's so. So I can't underscore enough how important that work was that Rick and his team have done and continue to do. The many prevention efforts, a coordinated prevention strategy that included multiple stakeholders, including community at the forefront of it. We have a local task force on COVID equity, and I'm a part of that. Rick is a part of that, and it's amazing work that this group has been able to do. And then we created something that one of our staff, who's a recent MPH from GW, Mary Catherine Crawford, she said, Doc, I want to get the word to policymakers. We talk about policy and the implications for policy, but I want to create something specifically that I send to them and their staffers each week so that the data is right there in their face in an easy to digest form. And also, give them the input that we get from community around what people would like to see. And so we created something called the COVID policy brief. And that is available. We'll throw the link up in the chat if you want to see it. It's been a real game changer for us. And some of the things that we put in there, we're starting to see movement and action around them.
Yeah. So we've got 2 slides left and about 2 minutes. And so my experience of working with that team on COVID specifically, like I said, I felt like it mirrored some of our work with respect to opioid use, with respect to the alcohol environments, food environment. I mean, it's really the general formula of being in the community, working with the community and for the community, as opposed to doing to the community. And, us being in Flint, like physically working in Flint and working and living in Flint, I think kind of allows this recipe to just keep going, no matter what it is we're looking at. So yeah, to build off Debra's point, I think equity approaches work, but they must be deliberate. I'm always going to tell you as a geographer that the built environment influences and reinforces disparities. As we found, we know that these clusters change over time. Something like crime may morph a little bit more slowly because the general patterns may be more similar. Food access may not change that much over time, but individual behaviors that are tied to these broader social patterns can change quickly. And so we need, like we said, good data availability. But it's all data-driven, equity-based for us, and that allows us to try to be more responsive with our community partners. And back to Deborah for the closing.
Yeah, so future directions for us, we encourage folks track disparities. When I was in graduate school, there was a different sort of approach. We kind of treated race and things like that as almost like a nuisance variable, and we sort of controlled it away or adjusted it away. And then we figured out that wasn't the best approach. It's not about understanding relationships above and beyond race or after controlling for race. We need to understand how race and the experiences that race give way to impact disparities, and what are the upstream interventions that we could implement that would intervene and sort of dam up that stream, if you will, so that those things don't roll downhill. A stronger emphasis on translation and dissemination and implementation research, and a big part of that is strengthening what we call the research to practice and policy pathway, and plugging up that leaky pipeline. NIH loves, and we all do it. I'm a NIH reviewer, it's like the shiny nickel, a good RCT and all of that. And dissemination and implementation science is really more of the science of how do we take things that we know work and get them up and out in communities without losing their effectiveness. And I think that's really where we need to be headed. And a part of that is also having funding agencies see value in that work and see value in engaging communities in that work as well. Because if you're trying to get things up and out and get them to stick and take hold, the people who you're trying to get it to stick with, whether it be providers or individuals or families, likely have some value that they can add there. And so I will say that our Strengthening Flint Family Study is not a trial. It is a hybrid trial. It's a hybrid type 3 dissemination trial. So we are still monitoring program outcomes and program effectiveness, but we're more looking at some of these institutional and uptake type factors that really give us insight on how to have these programs be maintained and sustained. And there's a graphic made by my wonderful Dr. Heather Lynn Uphold in my shop too. I see a bunch of them have Zoom bombed your meeting, and they all came in as Heather Lynn Uphold. So I just quick changed a few names.
I wondered what was going on with that.
I know she must have given them all her login, but that's okay. That's okay. And so, so the last thing, and I see some diversity in this group because I know a couple of these folks. This 17-year odyssey is not trivial. And the 17-year odyssey is it takes basically 17 years for 14% of research to ever be translated into practice. Where the other 86% goes, it dies on the vine, it lives in a journal, it's used for the next study. And I just feel like we can do better. Like we can and we should do better. So this, push for, action-oriented, equity-focused research is important. And to do that, we should be mandating equity, measuring equity, and attaching the outcomes that we want to the resources that we allocate.
So to close, I'm just briefly going to pause on this, but we will make these slides available. So these are the 4 papers that we touched on. In particular, we focused on these top 2 here. And then that's a couple ways to reach us, including in person if you're ever driving through Flint.
Yeah, and like and share on social media. I'm at Dr. Debra Furr-Holden. He's at Flint Geographer, and we did found the hashtag mandate equity. Hashtag mandate equity.